Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features content from an educational virtual symposium titled All Eyes on ExPEC, a major driver of invasive disease and antimicrobial resistance, featuring Dr. Lilian Abbo as the program director and Dr. Julie Justo and Dr. David van Duin as expert faculty. Dr. Abbo is an Associate Chief Medical Officer in Infectious Diseases at Jackson Health System and a Professor of Infectious Diseases at the University of Miami Miller School of Medicine in Miami, Florida. Dr. Justo is a Clinical Associate Professor for the University of South Carolina College of Pharmacy and Infectious Diseases Clinical Pharmacy Specialist at Prisma Health Richmond Hospital in Columbia, South Carolina. And Dr. Van Duin is a professor of medicine and director of the Immunocompromised Host Infectious Diseases Program at the University of North Carolina in Chapel Hill, North Carolina. In this episode, they discuss the burden of extraintestinal pathogenic E. coli, or ExPEC, risk factors for invasive disease and multidrug resistance, and the evolving vaccine landscape for ExPEC prevention. For the full educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what our faculty have to say about ExPEC.
Good morning, everyone. Thank you for joining us today in our webinar, All Eyes on ExPEC, a major driver of invasive disease and antimicrobial resistance. This educational activity is supported by an educational grant from Janssen Therapeutics and from Clinical Care Options and their entire staff who has made this webinar possible today. So thank you for joining us. I'm Lilian Abbo. I am the program director for this activity. I'm an associate chief medical officer for infectious diseases at Jackson Health System and a professor of infectious diseases at the University of Miami in Miami, Florida. Today, I have the pleasure of being joined by two outstanding faculty members, Dr. Ann Justo. She's a clinical associate professor in the Department of Clinical Pharmacy and Outcome Sciences at the University of South Carolina College of Pharmacy, and she's an infectious diseases clinical pharmacy specialist in South Carolina. Dr. David van Duin, also an esteemed colleague and professor of medicine. He's a director of the Immunocompromised Host Infectious Disease Program at the Division of the Infectious Diseases at the University of North Carolina in Chapel Hill, North Carolina. We're thrilled to have all of you here today, and we hope that you learn a few new things with this activity. Here are our disclosures that you can read them later. So the outline that we have lined for today is the first section is going to be ExPEC, a cause of concern. Then we're going to be discussing who's at risk. And then the last section will be great expectations, a path to reducing antimicrobial resistance. So I have the honor of introducing now Dr. Ann Justo, who's going to be presenting ExPEC, a cause for concern. Julie, the floor is yours.
Thank you, Dr. Abbo. So let's go ahead and move on to this first section where we're really going to dive into ExPEC and the diversity of strains that exist. Extraintestinal pathogenic Escherichia coli, or ExPEC, represent an important cause of infectious diseases in humans. Their pathogenicity is characterized by a combination of virulence factors, and the exact combination of said factors can vary pretty widely. This is an important thing as well, that ExPEC share features with opportunistic pathogens because the virulence factors that we've identified in ExPEC can also be found in commensal strains. So this is an important point, trying to differentiate ExPEC that cause human disease from the E. coli that are part of our normal microbiome is proving to be pretty difficult. To date, no specific set of virulence factors have been linked to clonal dissemination of ExPEC. Some of the hypothesized theories are that dissemination could possibly be due to drug resistance genes, which we will discuss, enhanced metabolic capacity, and or capacity for asymptomatic carriage. When you take all of these characteristics combined, all these factors make the development of a vaccine target against ExPEC particularly difficult. Now, before we can talk about the specific vaccines, it's important to understand what are we working with. Looking at the ExPEC outer membrane structure, you can see that E. coli possess a variety of surface antigens. All antigens represent the outer portion of the lipopolysaccharide on the surface of the E. coli cell. There are over 180 types of O antigens. K antigens represent the capsule of the E. coli cell. And again, there are over 80 types of K antigen. The third and final antigen type that is important for this discussion are H antigens that are comprised in the flagellum. And there are over 50 types of H antigens. When you combine specific antigens together, you can create characteristic serogroups across E. coli. So for example, you might refer to a specific serogroup as O157H7, which will tell you which type of surface antigens we're dealing with. So understanding there's more than just the outer structure of the E. coli that we're also going to potentially look at as vaccine targets, it's really important to understand how we classify different ExPEC organisms. And looking into the literature, we will find that there's three main ways that we would classify ExPEC. One is by strain, and that's further subdivided by pathotype or phylogroup, which we'll talk about in a second. Then there's a whole series of virulence factors, which we're also going to discuss some of the most promising of these that could be vaccine targets. And then finally, antimicrobial resistance profiles, which we're also going to touch on. So first, let's start by strain. E. coli strains can be subdivided by either pathotype or phylotype. Right now, you're looking at the four main pathotypes for ExPEC, okay? And these pathotypes are basically characterizing the disease presentation of that E. coli. So here you can see the table showing four different pathotypes: pathogenic E. coli, neonatal meningitis E. coli, sepsis-causing E. coli, and avian pathogenic E. coli. And they're frequently referred to by their acronyms listed on the table. You'll also see that the associated virulence factors, which each one of these particular pathotypes can be a very long list and can be varied across these different pathotypes. ExPEC are often defined as possessing at least two select virulence factors. But again, as you can tell, the average is many more than that. So for example, in one study of 120 adults with E. coli bacteremia, there were 108 distinct virulence factor profiles with a median of 9 virulence genes each. The disease presentations for ExPEC can extend past these pathotypes. So as if there are clinicians on this call, they'll also notice that these ExPEC can present as pneumonia, cellulitis, osteomyelitis, or other infectious syndromes. This slide here is for your reference. There are also intestinal pathogenic E. coli that are separate pathotypes. This is past the scope of what we're talking about today, but I just wanted you to understand that this schema of pathotypes would extend into intestinal pathogenic E. coli. So for example, you can have enterohemorrhagic E. coli, which can present as bloody diarrhea, or enterotoxigenic E. coli, or ETEC, which can present as mild to severe watery diarrhea. It's important to note that the virulence factors across these INPEC are different and also varied compared to ExPEC. So switching from pathotype to phylogroup, if you're looking at the bacterial genome, you can also identify variations to help classify these ExPEC into various phylogroups. The methods that are used in labs are varied, but one of the most common these days is multi-locus sequence typing. So that would allow us to classify the ExPEC by phylogroup, which can be further subdivided into clonal complexes and further subdivided still into sequence types. Many of you will be familiar with these sequence types. It is the identifying classification schema to a lot of clonal dissemination throughout the world. So for example, 20 sequence types currently account for about 85% of E. coli isolates causing infections. And the most prominent currently is the sequence type 131, which we'll touch on a little further during this talk. There are four major phylogroups across E. coli: A, B1, B2, and D. You'll notice the latter two, B2 and D, comprise the majority of ExPEC that we know of today. There are also minor phylogroups, C, E, F, G, and cryptic clade 1. Next, we're going to talk a little bit about virulence factors as an alternative classification schema for ExPEC. This part is pretty interesting. In contrast to INPEC, which focus a lot on exotoxins, ExPEC is very different. Its virulence factors focus much more on adherence to host tissues, such as adherence to the human bladder epithelium, and survival within the host tissues, especially human sera. So that's immune evasion in the form of evading antibodies and complement, or in having systems to improve nutrient acquisition, such as that of iron. Now I'm going to walk through 4 important virulence factors that have been found across ExPEC in a little bit more detail. The first are these surface polysaccharides that I talked about in the beginning. These same surface antigens, the O antigens, K antigens, and the like, can facilitate host immune system evasion. They can prevent opsonophagocytosis, complement-mediated killing, damage by antimicrobial peptides, and antibody binding by obscuring subcapsular epitopes. So each of these antigens can play an important role in the pathophysiology of ExPEC infection. O antigens, again, as a reminder, comprise that outer portion of the LPS, and there are a variety of different types that are being studied. K antigens, again, represent the polysaccharide capsule, and again, there are a variety of different types being studied. When it comes to these surface polysaccharides as vaccine targets, there's a high variety of them which exist, and it makes identifying a particular target challenging. In addition, some of these K antigens, such as K1, have been found to be poorly immunogenic in preliminary research because of their similarity to human host tissue. And so therefore, they would be poorly eliciting an immune response. In contrast, there is some data to support that a multivalent vaccine product targeting a mix of O antigens can be promising and is in further development. So Dr. Abbo will talk more about that in a bit. Shifting to another type of virulence factors with adhesins, these are extracellular proteins facilitating bacterial attachment to and or invasion of the host cells. So these basically represent the fimbriae and pili on the surface of the E. coli that allow it to persist and establish colonization and ultimately infection within host tissues. While this is not an exhaustive list, these are some examples of these adhesins that have been studied as vaccine targets. First is PAPG, which represent the tip adhesion on P. fimbriae, and this contributes to human kidney colonization. Then there's the DR fimbriae, which bind to type 4 collagen and DAF/CD55 on the tubular basement membrane and the Bowman's capsule of the kidney. So you can imagine this would be important in the pathophysiology of UPEC infections. Lastly, there's type 1 fimbrial adhesion FIMH, which binds to mannose residues of uroplakin of the bladder epithelium. What's interesting about FIMH is that expression can in fact be turned off once infection takes hold, potentially allowing those uropathogenic E. coli to evade the immune system. As vaccine targets, these adhesins have prevented infection somewhat, but they have a limited impact on the even earlier step of colonization in animal models. So there's a little bit of work yet to do in this space. Going to our third type of virulence factor of toxins, these are proteins that are associated with increased inflammation, bladder epithelial cell damage, and renal damage. Again, this is not an all-inclusive list, but important examples in this space include alpha-hemolysin, which is a calcium-dependent pore-forming cytolytic toxin that's associated with invasion, cytokine release, inflammatory response, and host cell lysis. You can imagine those organisms that are secreting the alpha-hemolysin would be associated with more severe disease. And the same holds true for these other examples like cytotoxin necrotizing factor, which is associated with cytoskeleton disruption, binding, and invasion into host cells. And the last example of autotransporter toxins, which are associated with renal tissue damage and specifically vacuolization of the kidneys. So as vaccine targets, these toxins have a minimal ability to prevent infection, but they may decrease infection severity in animal models. So this may be a space where we can combine some toxins with some other vaccine targets, particularly to help decrease infection severity. The last type of virulence factor I want to discuss are iron acquisition systems. These scavenge and acquire essential iron in the host environment that allow ExPEC to survive within the human body. They also exhibit a role in colonization, biofilm production, and the formation of intracellular bacterial communities. These latter IBCs being particularly important in things like recurrent ExPEC infections, such as urinary tract infections. So siderophores and outer membrane iron compound receptors represent these iron acquisition systems. The siderophores are small, organic iron chelating molecules that compete with host proteins to scavenge for that ferric iron. Examples include enterobactin, salmokinin, and others. The outer membrane iron compound receptors allow the entry of those same siderophores into the bacterial cell, and they also allow entry of other iron-containing host molecules such as heme or other iron-containing host molecules of other microorganisms within the human body. As vaccine targets, prelim research suggests that vaccines with multiple outer membrane receptors may be necessary for effect. All right, last we want to switch to the third classification schema for ExPEC, in this case, antimicrobial resistance profiles. Many ExPEC possess various antibiotic resistance genes and exhibit phenotypic resistance to antibiotics. So for example, in more recent research, ExPEC strains ST131, 69, and 393 comprised 30 to 46% of the drug-resistant E. coli isolates in those studies. One of those studies is shown on the right. You can see this was a study of 500 extraintestinal E. coli isolates in Spain from February 2009. Those three ExPEC strains represented 19% of all of the clinical isolates. However, they made up 30% of the subset of multidrug-resistant isolates, which was about 60 from the entire cohort. What's interesting, though, is that the resistance phenotype does not appear to be the sole determinant of clonal dissemination of ExPEC. For example, resistance profiles are not always present in some of these sequence types that are undergoing rapid clonal dissemination, like ST93, which was relatively susceptible at the time that it emerged. In addition, other sequence types have resistance that can vary widely over time and over geographic regions. So for example, ST131, it's changed in the specific predominant resistance mechanisms and profiles that it's had by time and also by country of origin. It's somewhat difficult to describe the overall scope of ExPEC antibiotic resistance. So what we've tried to do is in the next two tables summarize common antibiotic resistance profiles across 4 of the most common classes that would be used to treat ExPEC infections. The two listed here are for beta-lactams and sulfonamides. You can see with beta-lactams, there are specific resistance mechanisms that are comprised and found within ExPEC. One of the most prominent being extended spectrum beta-lactamases, or ESBLs. You can see some examples of specific genes within that group of ESBLs. A very common one that we would find here in the US and South America and other parts of the world is CTXM. Okay, this represents enzymatic inactivation of the drug and is common in, for example, ST131. Other examples of enzymatic inactivation of the drug are also found within ExPEC, including AMP-C beta-lactamases and carbapentamases. The carbapenemase genes KPC and NDM are, again, very prominent in certain parts of the world. The next class of antibiotics that's really important is sulfonamides. So this specific resistance mechanism in ExPEC includes mutations in dihydrofolate reductase that alter the target binding site of your sulfonamides and can render them inactive. And this is important because sulfamethoxazole trimethoprim as a combination drug represents one of the first-line treatment options for a lot of urinary tract infections caused by ExPEC. 2 other classes to round out this discussion about antibiotic resistance are fluoroquinolones and aminoglycosides. Fluoroquinolones, man, there's a lot of different ways that ExPEC can render fluoroquinolones inactive. Top of which being most common, you've got mutations in DNA gyrase and or topoisomerase 4 that alter the target binding site of the fluoroquinolone, rendering it inactive. And those are commonly found in ST131. You can also have mechanisms such as porin channel downregulation, efflux pumps, and acetyltransferase enzymes that can render fluoroquinolones inactive. Aminoglycosides, it's really that enzymatic inactivation from the acetyltransferase enzymes that drives a lot of resistance to aminoglycosides across ExPEC. I'm going to round up this section by focusing on some of the implications of some of those beta-lactamase enzymatic inactivation mechanisms for resistance when it comes to ExPEC. This table is showing you the family of beta-lactam antibiotics. So as you can see here, we have lots of different options, and these generally represent some of the safest and most effective agents to use against ExPEC infections. Here's a picture of what happens when that organism is producing extended spectrum beta-lactamase. So again, as a legend, you can see in red that all those agents in red would not be expected to have in vitro activity against an ESBL producing ExPEC. Those in yellow have variable activity, and those in blue remain active. According to the Infectious Disease Society of America guidance for treatment of antimicrobial resistant gram-negatives, the beta-lactams of choice for serious ExPEC infections that are producing ESBLs would in fact be carbapenems, which are those agents highlighted in green on the table. Here's an example of what would happen if that ExPEC was producing ANTCs, which is a distinct and separate but aligned beta-lactamase enzyme. You can see the situation gets even worse, where you have the sapromycins are no longer active in vitro, and some of our older beta-lactamase inhibitor combinations are fully inactive as well. Beta-lactams of choice for these types of infections, according to that same IDSA guidance, would be either cefepime, which retains activity against AMC beta-lactamase, or those same carbapenems. Here's an example of what happens with a carbapenemase, specifically a KPC. It knocks out even more of the family of beta-lactams. And again, the beta-lactams of choice for serious ExPEC infections would be a very limited list, such as ceftazidime avibactam, or meropenem vaborbactam, or imipenem cilastatin relebactam. And all of these have in common that they have novel beta-lactamase inhibitors that have been developed and brought to market in the last few years. And then lastly, here's another example of metallobeta-lactamase, which can knock out carbapenems. This one is specifically Delhi metallobeta-lactamase, or NDMs. And this is probably one of the worst situations that we have, where really we're left down to using a combination of aztreonam plus avibactam in the form of ceftazidime avibactam, or cefiderocol as an agent within the beta-lactam class that could potentially treat serious ExPEC infections. So again, the focus of this was not the details and nitty-gritty of treatment, but you can see how these antibiotic resistance profiles can really limit our treatment options for these patients. So key take-home points: ExPEC strains can be characterized by various schema: pathotype, phylotype, virulence factors, and/or resistance genes. There's no specific set of characteristics clearly linked with clonal dissemination of ExPEC to date. Future vaccine targets will likely need to be multivalent and come from different areas to address this complexity. ExPEC are known to possess various antibiotic resistance mechanisms, and reliance on antimicrobial therapy alone will likely drive further antimicrobial resistance within ExPEC. So we need another answer. With that, I'll turn things over to Dr. David van Duin to discuss ExPEC, who's at risk.
Thank you, Dr. Justo. That was a wonderful talk. So we'll talk about who's at risk now for these dangerous bacteria. E. coli, we mostly think of as an important cause for urinary tract infections first and foremost, and then also bloodstream infections, and those bloodstream infections are often secondary to a urinary source. And here in these graphs, you can see that over this period of time shown from this specific study, but this has really continued over time, is that we've seen this increase in cases of urinary tract infections and also in the associated cost. And that has been more predominant in women than in men. E. coli can also cause a whole host of other infections, including infections that you may pick up in the hospitals, and nosocomial infections. And also it's an important bug to cause neonatal meningitis. So let's talk a little bit about prevalence. So when we look at the prevalence and then also the impact for bloodstream infections, you can see that E. coli really has a very large impact when you put it into context of other important pathogens. So here you see that on one axis, you see the number of positive episodes by each organism, and then the associated mortality is shown. So the associated mortality is relatively lower with E. coli as compared to things like Staph aureus. But because it's so common, the overall impact as depicted by the size of the circle is quite high. Similarly, the global impact of resistant E. coli is the highest of all resistant organisms. And here in the blue bars, you can see that the number of deaths globally associated with resistance in 2019, and in red, those that were directly attributable to resistance. And in both categories, E. coli was the most important pathogen. overall, all these pathogens combined, there were about 5 million deaths associated with bacterial AMR and about 1.25 million deaths that were directly attributable to bacterial AMR in 2019. So very important problem. This extends also to the US, and antibiotic-resistant bacteria and fungi cause about 3 million infections and 35,000 deaths. And then C. diff, which is an important antibiotic resistance-related pathogen, causes over 200,000 cases and 12,000 deaths. So then digging into that a little bit more and using one of the classifications that Dr. Justo went into, looking specifically at those bacteria that either produce ESBL or that are carbapenem resistant, you can see that we have some data from the CDC. And because you'll hear those numbers quite frequently, I just wanted to give you a little bit of background on where they were derived from. So these estimates from CDC are based on these large databases that altogether represent over 20% of U.S. discharges. So really a good sample size. From that sample, they then extrapolate to the rest of the U.S. These estimates exclude surveillance cultures, for instance, a rectal swab done simply for the purpose of surveillance, but it doesn't distinguish specifically between infection versus colonization. So, for instance, cases of asymptomatic bacteriuria, which of course are quite common with E. coli, would be included as cases. And if you read through this CDC report, you'll see that the term infection is pretty carefully avoided with these estimates. So looking overall at cases for ESBL, we're almost at 200,000. For CRE, that number is significantly lower at 13,000, and then associated deaths at 9,000 and 1,000, and lower but significant numbers associated with healthcare exposure. And in that same CDC report, they looked at the trend over time between 2012 and 2017. And for ESBL producers, a strong increase was seen, whereas for carbapenem-resistant Enterobacterales, that trend was stable. And here you see that trend for ESBL. So really a quite remarkable increase over that time. And again, that trend has pretty much continued from 2017 until current. But of course, we don't have this same level of data for later time periods. The reason for these increases is thought to be primarily mediated through spread in communities. So whereas strict hospital onset cases, and this is shown just from one study, but there's multiple studies that show these same trends, that hospital onset cases remain relatively stable, but that you see these healthcare associated and community acquired cases really strongly increase. And these are some slightly older data ranging up to 2014, but similar trends have held true since then. And you heard a lot about sequence types already, and it's just really important to sort of keep your eye on those developments. SD131 was already highlighted as an important one. And one of the reasons that this is such a threat is that it combines these three things that we're worried about. So it's a highly resistant strain. It often carries resistance to quinolones as well as to beta-lactams, to ESBLs. It has all these virulence genes that Dr. Justo already went over. And then it's also highly transmissible. And there's many, many cases where you can see sort of a direct documented transmission of the exact same bacteria going between household members, going from pets to humans, going from food to humans. So really quite worrisome. Looking then at what's been going on over the last couple of years with COVID, this was a nice study looking at bloodstream infections. And what I should highlight here is that we're looking at percentages. So the overall percentage of bloodstream infections that is caused by E. coli was high before the pandemic and has remained high during the pandemic. Similarly, for those that are caused in the community, so the CO BSI, as well as those that are associated with the hospital onset HO BSI. And this is in the setting of overall BSI being strongly increased during the pandemic. So all of these cases and all of these causes have really increased, but the overall distribution has shifted only very slightly to seeing a little bit more Staph aureus and a little bit less E. coli, but overall being fairly stable. Then the next, we would talk about the populations at risk. So looking first at recurrent urinary tract infections, this is, of course, a very troublesome and quite common issue, defined as having more than 2 symptomatic episodes within 6 months or more than 3 symptomatic episodes within 12 months. These tend to be more common in women than men, with a risk increase of about 30-fold. And 20 to 30% of people have more than one recurrence of UTI within 6 months. And then some risk factors, but it's important to note that this is from a study looking at young women up to 29 years old. Some risk factors for recurrence are listed in this table. But of course, a lot of patients that we see with this issue tend to be older women who don't fall into this study population. Then some risk factors for complicated UTIs. So those UTIs that may be more difficult to treat or require additional treatment. And you can put them in sort of 5 categories of immunosuppression, so things like renal insufficiency or having diabetes or being on medications that suppress the immune system. Nosocomial factors and instrumentation, and you see some examples there. So that could be having an indwelling catheter, which is of course quite common, or having a stent, or maybe some surgery on the prostate. Anatomic abnormalities, such as in polycystic kidney disease. Urinary tract obstruction can be quite common, like with kidney stones or other issues with obstruction. And then voiding dysfunction is an extremely important one because it's often irreversible and very difficult to deal with, such as in MS or with a neurogenic bladder. And those tend to be patients who you'll see over and over again returning with urinary tract infections, and usually with escalating resistance profiles and with urinary tract infections that are more and more difficult to treat as time goes on. Looking at bloodstream infections, this is a nice study from Canada at the population level. So they looked at 2 things. One was the risk factors for getting a bloodstream infection. And then separately, if you've had a bloodstream infection, what is then the risk of dying as a consequence of that infection? So in the table, you can see the risk factors for that getting an infection. And you see that it's higher in those risk groups, like being on dialysis, having an organ transplant, patients with cancer. And when you look at risk factors for mortality, one protective, so the way you see the little estimate dot on the other side of the one is if there's a urinary tract focus, there is actually a lower mortality associated with that. So that tends to be easier to treat, and patients tend to have better outcomes. Conversely, if you have a focus outside of the urinary tract, there is an increase in mortality. Other things that are associated with mortality that are important to point out here are the impact of age. So you see that with an age of 65 and older, and then also even in those 40 to 64 as compared to those younger than 40. So some important risk factors listed there. And looking a little bit more at the impact of aging, so we know that age-associated changes in the immune system lead to that increased risk for invasive disease with E. coli. And that you can see that with this aging population that we have in Europe and in North America and in many parts of the world, actually, that this risk overall on a population basis is just going to continue to increase. Then looking specifically at multidrug-resistant organisms and multidrug-resistant E. coli, the most important two risk factors for having an infection with a multidrug-resistant organism are being treated with antibiotics or already have had an MDRO in the past, either as a colonization or an infection. Some other important risk factors include hospitalization history, being in long-term care like a nursing home, having some sort of a medical device like a urinary catheter, and again, older age here as well. So then the question, of course, always is, where are these pesky bacteria coming from? And we have some data in solid organ transplant recipients. And as you can see here in solid organ transplant recipients, after kidney transplant, similar to the example that we just showed, Enterobacterales, of which E. coli, of course, is the prime member, the most important member quantitatively, are really the most important for bloodstream infections after solid organ transplant, no matter what period after transplant you look at. Conversely, in liver transplant patients, initially Enterococcus is actually a bigger problem, but then as you get further out after transplant, once you're 2 to 5 years out, again, Enterobacterales become the most important. And thinking about then the origin of those infections is there's a lot of data now becoming available that really quite clearly show that the gut is really the reservoir for these organisms. So there's a couple of studies that I'll go over. This was a very nicely done study, single center prospective cohort done over 2015 to 17, where they did these weekly swabs to look for either ceftriaxone-resistant E. coli or CRE after transplant. And they found that in a cohort of 162 patients, 40 were colonized with multidrug-resistant E. coli, and 122 were not colonized. And when they looked at what happened to these patients, if you were colonized, you were much, much more likely to develop an infection. And especially in the most resistant subcategories, in the CRE, the carbapenem-resistant subcategory, that risk was especially high at 53%. And then in that same study, when we look at the outcomes, in the graph is shown the infection-free survival. So you see that's much decreased. And also the mortality rates in the patients after they got an infection were 6% at 30 days and 12% at 90 days. And those that survived their initial infection, many of them had recurrent positive cultures, and 7 out of 16, so quite a large number, developed recurrent infections again. So really emphasizing the impact of colonization in these more vulnerable patients. Similarly, in stem cell transplant recipients, and this was a very nicely done study where they had stool samples of patients that were collected prior to getting a bloodstream infection. And in a lot of these patients, and one example is shown here, you see that before the actual infection, which is denoted by day 0, you see really a predominance of E. coli in the microbiome. So almost all of the bacteria that you find in the stool are E. coli, which is really just quite amazing. And it's not a surprise then really that you start seeing these bloodstream infection in the setting of immunosuppression. And again, there's further evidence that you find these ExPEC in the gut, which is in a way a little bit counterintuitive, of course, because we're talking about ExPEC outside of the intestines. But as the reservoir, certainly the gut is most important. So this was a study from New York where they looked at fluoroquinolone resistance in patient stem cell transplant recipients who then got levofloxacin prophylaxis. And as you would expect, those patients who are colonized with quinolone-resistant organisms were much more likely to develop gram-negative bacteremia, especially with those quinolone-resistant organisms. So, as the key take-home points, ExPEC is responsible for causing severe invasive disease, contributing to increased mortality and healthcare costs. The presence of antimicrobial resistance increases these burdens. Several patient populations are at risk for these infections, and identifying risk factors for developing invasive ExPEC infections, especially MDRO infections, and then, of course, also the associated mortality, may help identify patients who might benefit the most from a vaccine. So let me stop there, and I'll turn it back to Dr. Abbo.
Thank you, David. So after these two wonderful presentations, we're going to be moving forward in the next 25 minutes to talk a little bit about, the future, a path to reducing antimicrobial resistance and what's coming up. What are the emerging vaccine technologies and what are the targets for these vaccines? So as Dr. Justo mentioned, there are multiple mechanisms of resistance, and the same way that these bacteria use this to evade our immune system, we can use them for potential targets for vaccine development. So there are three main targets that are currently being investigated. One is the surface polysaccharide, and more specific, the O and the K surface antigens. The fimbrial adhesins, as you can see in this graph as well. The FIMH is a possible target because it allows for E. coli colonization in the bladder, and if we can eradicate that, we can potentially eliminate the colonization and the biofilm formation in the urothelium. And then the outer membrane vesicles are also some potential promising targets, more than the outer membrane iron receptors or the toxins, which are also being investigated. So when we look at the polysaccharide vaccine targets, targeting the surface polysaccharides, the real goal is to identify factors that these pathogenic E. coli are expressing and that are not expressed by the commensal E. coli. So what we're trying is to protect our gut flora, right, this microbiome that we all need, and maybe just target the pathogenic antigens. So when you look at this graph, the surface antigens are O, K, and H, and the locations are on the lipopolysaccharide surface, in the polysaccharide capsule, or in the flagellum. And there are over 180 O antigens that are going to be on this LPS. So they really seem to be promising targets. The K antigens, or the K1, are considered, but they resemble more the glycoproteins that we have in our human neural tissues. So that potentially could have more adverse side effects. So when we look at, O and K, we really need to look at how our immune system is going to recognize, and whether it's also phagocytosis or complement-mediated killing, and also how they may cloak subcapsular epitopes on the bacterial surface by blocking the recognition by our host antibodies. We also look at the ICU, intensive care unit, distributions of these O serotypes in ExPEC. And when in this study that was published in 2021, they analyzed in the Netherlands about 70 samples, and 68 isolates were serotyped. So as you can see, the most common ones were the O25, which were about 16%, and the O8 with 7%. And then there were others, O2, O6, and O15 within the O serogroups. So So the theoretical coverage of a 10-valent vaccine would be about 54%, which covers about 56% of the community onset E. coli and about 53% of the healthcare-acquired bloodstream infections. So as you can see here in orange, you have the occurrence of these O polysaccharides, and here you would have in blue the 4-valent or the 10-valent vaccine that would provide potential coverage. When we look at the global distribution, again, the previous one was a study in the Netherlands. In the global study, they looked at 3,217 blood culture isolates with ExPEC from Europe, North America, Asia Pacific, and South America in a period of between 2011 and 2017. And the MDR frequency was almost 11%, of which the most prevalent, 63%, was again O25. So when you look at here, again, in orange, you will see the individual agglutination, and then in blue, you have agglutination and the cumulative agglutination prevalence with genotyping. So again, we want to make sure that if we're going to develop a vaccine, we need to make sure that it covers the most prevalent serotypes, including O25. So what are some of the obstacles? As you can see, if this was so easy, we would have already have tons of vaccines out in the market. Well, first of all, we need to make sure that the vaccine is able to generate a robust mucosal adaptive immune response. And some of the problems that we have is that E. coli can remain dormant in the bladder or on the epithelial surfaces for a long time. And then by creating these bacterial communities and biofilms, it might become more challenging to attack them. We also require novel approaches, maybe new antigen delivering systems and the use of adjuvants. The second barrier that we have to overcome is the severe local and systemic reactions, especially by the O polysaccharides. So we might require detoxification by removing through hydrolysis some of these lipids prior to administering that to humans. So by improving that, we might limit the immunogenicity, and we might require a protein conjugation or an adjuvant to induce an adequate immune response. There's also something that we all need to understand, that there are vaccines that are prophylactic and there are therapeutic vaccines. So the prophylactic vaccines are being used for the prevention, right, of these recurrent infections or primary infections. And as we know, most of the vaccines that are universally used are actually to prevent either childhood or adult onset diseases like pneumococcal disease or, Haemophilus and meningococcal vaccines. And we also have the annual, viral vaccines like influenza and now COVID. Therapeutic vaccines are really for at-risk populations already colonized or infected with the pathogen. So what's going on with these trials for ExPEC? Well, there are actually trials looking at both prophylactic and therapeutic vaccines. And there are some that are looking at parenteral routes versus oral routes of administration. So as you can see here, we have highlighted 4 clinical trials, the ExPEC 9V, which is currently on a phase 3 and it's enrolling, and it's estimated that the completion date will be around May of 2027. So for this vaccine, they're including patients that are older than 60, equal or older than 60, with a history of UTIs in the last 3 years. And the primary outcome is the first occurrence of invasive ExPEC disease of 9-valent serotypes with microbiological confirmation in blood, urine, or other sterile sites. So this is a prophylactic vaccine, and it's targeting the conjugate O polysaccharide, also with a Pseudomonas aeruginosa exoprotein A. The second vaccine that we have lighted in this table is the FIMH, and that one is using the bacterial adhesive protein of the FIMH as an antigen with a TL, toll-like receptor 4 agonist adjuvant. And this one is a therapeutic vaccine, parenteral route, and it's on a phase 2 trial at this time. The third one is the OM89. It's a subunit outer membrane vesicle. It's from an heat-inactivated E. coli membrane proteins, and it's actually both therapeutic and prophylactic. And the route of administration is oral, also on a phase 2. And then the ExPEC 10B, it's a subunit conjugate O polysaccharide. It's bioconjugated to the carrier protein, and it's prophylactic parenteral on phase 1 to 2 trials at this time. So ExPEC 4V Now, it's another study that is being conducted to investigate the effect of these vaccines for women with recurrent urinary tract infections. And that's a randomized, single-blind, placebo-controlled phase 1b trial. It was published in 2017. It was targeting healthy women between 18 and 70 years of age with self-reported history of recurrent urinary tract infections. So they needed to have at least 2 infections in the last 6 months or 3 infections in the last year, with at least 1 urine culture with E. coli preceding 5 years and in general good health. And they had 3 groups: the targeted dose, which had the largest group, a reduced dose, or a placebo that had 95 patients. And really what this was targeting as a phase 1 trial was more towards adverse event incidence. And then the other endpoints were immunogenicity, antibody functionality, UTI incidence caused by E. coli serotypes, O25B, O1A, O2, and O6A. There's a busy table, but what we wanted to look at is at the comparison in the safety of this vaccine versus the placebo group. So when you look at any severity, they were pretty similar for any event, about 47% of the patients in the placebo group versus 56% in the ExPEC. And then mild to moderate, where the majority of the effects were mild, especially in the intervention group as well as in the placebo group. Most of the adverse events were injection at the site with some pain at the site of injection. That was mild to moderate, mostly mild. And then some swelling, both on the placebo and on the control group. However, we see more headaches on the intervention group compared to the placebo, and then also a widespread of small and mild events like dizziness, fever, chills, diarrhea, loss of taste, extremity pain, hyperhidrosis, warmth at the injection site, and also in 2 cases, abdominal pain. So when we look at this trial, the immunogenicity and the UTI incidence, again, this was a secondary endpoint. The vaccine induced significant IgG responses for all serotypes. Again, this was comparing D30 versus baseline. So when we look at the serotype O25B, was 5.6 times higher. When we look at O2, for example, was 9.4 times higher. The antibody functionality was seen with opsophagocytic kill activity, and there was no reduction of UTI incidence with more than 10 to the third colonies compared to placebo. So as you can see, it has mild side effects, mostly mild to moderate. It has a pretty strong immune response, however, not yet, clinical reduction of the symptoms. But in the post-op analysis, they did find fewer UTIs by E. coli of any serotype, and that might be potentially promising. So again, this was just a phase 1 trial and more information is needed. When we look at Stella, which is the ExPEC 4V in healthy adults, this was a randomized double-blind placebo-controlled phase 2 trials. So in this one, they took healthy adults more than 18 years old with a BMI of greater than 35. And this was a larger study with 848 patients divided in 5 groups. And they looked the same way at the antigen content, and they dosed with different contents, group 1 to group 5. And you can see the differences here. And they were compared to a placebo. The primary objective this time was safety and tolerability, immunogenicity, and determination of a dose-dependent immunogenicity 15 days after the vaccination. And this trial was published in Lancet ID in 2019. So when we look at here at the safety in healthy adults, we have on the left hand, you're going to have the placebo, and then we have the different groups. Group 5, as you recall, have the highest antigenicity, and then group 1 had the lowest ratio. So when we look at any solicited adverse events, as we move to the right of the table, we see a little more solicited adverse events, such as pain compared to the placebo group, erythema, swelling, and when we look at the median days of onset, it was around the same except for group 5. So on group 5, we saw between days 1 through 8, with a median of 6 days onset of adverse events, whether in the lower dosing groups, closer to placebo, 1 to 2 days. When we look at any solicited adverse events, we see 35% of the patients had any adverse events. But when we go to group 4 and 5, it's between 43 and 51%, with more fatigue and headaches and nausea compared to the placebo group. And the median onset of any adverse events, when we look at and this range is the same. It's 1 to 2 days. So the immunogenicity here, it's also a basic graph, but what you can see here is we have in different colors. The lighter blue is placebo, and you can see dark blue or teal is group 1, orange group 2, green group 3, purple 4, and yellow you're going to see group 5. And you're going to see that at day 15, more than 80% of the participants had a twofold increase in the serotype-specific IgG. And the immune responses for ExPEC 4448 and 8816 dosages persisted after 1 year. So that's actually more promising. We may not need the highest dose, but we're, again, more information to follow on this. So what about the FIMH vaccines? So there is an open label dose escalation phase 1 study that assessed the FIMH vaccine safety in 67 healthy women with history of recurrent urinary tract infections. No serious adverse events were reported, and the vaccine induced both binding and functional antibodies. Women with history of recurrent UTIs demonstrated 150-fold increases in antibodies against the N-terminal region of the FIMH, and this was published last year in 2021. When we look at the OM89 vaccine, there's also a more older study from 2005. It was a multi-center double-blind study in 52 sites in Europe, and they found that the OM89 significantly reduced the UTI incidence 12 months of the study compared to placebo. And this was statistically significant in 453 patients that were studied. So there was a 34% reduction in UTI using this target. And they had different groups. And the study initially had, in the first 3 months, 1 capsule daily, more 4 to 6, no treatment. And then 7 to 9, they did a booster with 1 capsule for the first 10 days of the month. And the study was completed after 12 months. So what are some of the possible downfalls with vaccines? As you can see, over a decade, there are different groups trying to investigate how we can make this happen. Well, first, we need to remember that there could be selective pressure, and we have, the polysaccharide 7s and the emergence of serotype 19A that could be having some immune evasion. Very rarely, we're going to see vaccine resistance. We see that more with other organisms or with antibiotics. Typically, vaccines are going to have different epitopes that are going to be protective, and vaccine resistance will require more mutations that will require antibiotic resistance. So that's why vaccines are potentially promising targets for antimicrobial stewardship and also to decrease the development and the burden of these antimicrobial resistant infections. So if we look at this table in the top, you're going to see antibiotics, and in the bottom of the graph, you see viral vaccines. And in green, we're going to have the bacterial vaccines that actually have been developed. So when you look at the antibiotics, from the time of development, from the onset of development of sulfas and penicillin, we saw that in less than a decade, these antibiotics already were becoming resistant to some of these bacteria, because bacteria spread very rapidly their mechanisms of resistance. And unfortunately, as the more antibiotic pressure we put in the environment, these bacteria become smarter and will find ways to evade them. So as we see with almost every antibiotic, at some point or another, there has been development of antimicrobial resistance. And that continues to be a challenge, as we need to invest decades in the development of these drugs. We need to invest billions of dollars. By the time they are able to go into the market and we're able to use it, sometimes they already become resistant. So what happens with vaccines? As we see here in the bottom, development of vaccine resistance could happen, but it tends to happen much later. And as we see here with pertussis and pneumococcal and hepatitis B vaccine, there has been resistance to some of these vaccines, but in general, it's much more difficult. Therefore, that's why we continue to say that eventually it would be great if we could have more vaccine development, not just for ExPEC, but for many infections. So what are some of the benefits that vaccines have? Like we mentioned, we know that the more antibiotics we use, we're going to be driving antimicrobial resistance, whether that's appropriate or inappropriate use of antibiotics. We also know that poor infection control practices spreads antimicrobial resistance, lack of hygiene. In many parts of the world, there are people who don't have access to potable water or even toilets. And then we live in a global world. So the lack of development of new antibiotics, also it's a global problem. So with development of vaccines and decreasing the antimicrobial pressure, we know that we could reduce antimicrobial resistance. And we have seen that, for example, with pneumococcal vaccines, and as we're going to be seeing in this graph. So with the PCV13, there has been a dramatic reduction, not only in mortality across the world, but also when we compare that in parts of the world that these vaccines are not widely available, we continue to see high mortality. And we also know that with the use of pneumococcal vaccines, there has been a significant reduction in the use of macrolides, cephalosporins, tetracyclines, and penicillins. When we also look at other success stories from vaccines, we look at the Haemophilus influenza B vaccine. We've seen a reduction in severe, in production of beta-lactamases since these vaccines were introduced, less infections in children and less use of antibiotics in these children. We also know that when we use influenza vaccines, widespread and in flu seasons, we decrease the inappropriate use of antibiotics as people are less likely to have viral infections or secondary bacterial infections. So 64% decline in antimicrobial prescriptions after deploying universal influenza vaccines in Canada, for example, in Ontario compared to other Canadian provinces. So what's the framework that the World Health Organization is using to license vaccines to maximize the impact of antimicrobial resistance? And I think this is a busy but very important graph. First of all, we really need to increase the coverage of vaccines that will have an impact on antimicrobial resistance. Second, we need to, they have updated the recommendations and guidance, and we really need to ensure that globally we understand what's the role of vaccines. With so much mistrust in science and everything that we have seen in the last 3 years with COVID, it's really important that people understand the importance of vaccination in all stages of life. 3, improve awareness and understanding of the role of vaccines limiting AMR. We need more funding for research and development for safe vaccines, and develop regulatory policies to accelerate the approval and use of vaccines, just like we saw with COVID. We can't wait another decade to develop a vaccine for E. coli, for ExPEC, or for other antimicrobial resistant organisms. We also need to improve methodologies and increase the collection and analysis of relevant data so we can share that data globally and in a timely manner. And number 7, we need to develop estimates of vaccine value to avert burden. So we really need more economic analysis and understand what's the impact globally in our economies. So what can we do now? Well, we really, as we're all here, all 3 speakers in this talk, we are big proponents of antimicrobial stewardship. We firmly believe that stewardship improves clinical outcomes. It minimizes harms. The better we prescribe antibiotics, the better work we do for our patients. We can avoid treatment failures. We can prevent C. difficile infection or recurrences. We can prevent adverse events from unnecessary antibiotics. We can decrease or slow down the development of antimicrobial resistance, and we can impact the bottom line, the hospital costs and length of stay. So what are the 5 Ds of stewardship? It's the right drug for the right time, for the right duration, for the right diagnosis, and for the right de-escalation, which is very important. And some of the approaches that each of you can take to contain antimicrobial resistance are really looking into what are we doing to invest in new drugs, new tools, new vaccines and interventions. What kind of research can you do in your practice to help expedite and move this field forward? How can we optimize the use of antimicrobials and avoid the unnecessary antibiotics in both humans, animals, and agriculture? What can we do to improve awareness and understanding of antimicrobial resistance in our schools, in high schools, in universities, medical schools, and in the general population? We also need to strengthen the knowledge and evidence through surveillance and research, which is critical. And we also in the COVID pandemic, how important it is to have these surveillance mechanisms. And like we do for viruses and understanding these strains, doing the same thing for bacterial and bacterial development and resistance, it's really important. And then we need to continue to be big proponents of infection prevention. Really, hand hygiene, it's key. And cleaning the environment and preventing the horizontal transmission or vertical transmissions, it's really important. So part of those preventive mechanisms could be through vaccine development, but elbow grease and water and soap continue to be very, very important mechanisms to prevent the transmission of resistance from one person to another. So what are some of the key take-home points of this last section? 1, vaccines targeting ExPEC remain an active area of research. We learned that current targets include the O polysaccharide, the FIMH, and the outer membrane vesicles. We all learned that there are phase 1, 2, and 3 clinical trials that are ongoing, but we're still pending some more clinical outcome data. We also learned that there are IV and PO vaccines being studied. There are several benefits of vaccines, that they're not limited to decreasing infections, reducing mortality, decreasing antimicrobial use, and slowing down and stopping the development of antimicrobial resistance, as we can preserve the effectiveness of the antibiotics that we need. And unlike most current vaccines, the ExPEC vaccine is predicted to target perhaps a niche patient population, and that's to be determined who will benefit the most, who are the highest risk populations, and that's where we need the clinical studies. And last but not least, the judicious use of antimicrobials through antimicrobial stewardship remains a very important way to prevent ExPEC infections and to reduce antimicrobial resistance. So please do not treat those asymptomatic bacteriurias. Treat symptomatic patients. Use your antibiotic wisely. Now that you understand the mechanisms of resistance and how this spreads and how we're losing some of our effective antibiotics to combat these infections. So I'm going to move next to our questions. We have about 5 to 10 minutes. And one of the first questions that came is, in our estimation, how close is vaccine availability for ExPEC? So as we mentioned, one of the trials, the 9V ExPEC vaccine trial, is estimated to be completed by May of 2025, and the completion date, the primary is 2025, but the completion date is estimated for 2027. So we need more research and development and expedite some of these studies, enrollment, and approvals pathways, as I don't think we can wait 10 more years or 7 more years for these vaccines. I have some questions for my co-speakers. So, Julie, I'm going to call up to you, and David, I'm going to call you after. So, what do you think of a routine universal vaccine recommendation? And if approved, which settings do you think would be best to use these vaccines, Julie? Would you recommend it as a pharmacist on the inpatient side or on the outpatient side?
Yeah, I think that's kind of the big question that a lot of us had when putting together this talk, or if you're kind of dabbling in this space, trying to pay attention to what's coming down the pipeline. Where is this going to be placed? How do we get patients access to this? Where does it have the best chance of effectiveness and safety? I am, at this point, with the data that we've presented here today and the data that is out there, I'm not quite sure I see a routine vaccination across the board. I definitely think it's plausible if the phase 3 trials bear out for specific vaccine products. We could get to a situation where we would have a vaccination recommendation for patients 60 years of age and older, or for women that have a history of recurrent UTIs, or for patients that are immunocompromised or something like that. I think that is plausible and most likely where I would see this placed. Whether or not that ends up in the clinic or in the hospital, I think that's to be determined based on the indication of the product. Most likely, I would imagine we would do a blended situation where if it is a niche patient population that's at risk, if they're found in either the clinic or in the inpatient setting, that we could provide them access. Like with most of the vaccine products, once we know that we have a good product that's safe and effective, we would try to deploy that in as many places as possible to gain patients access to that treatment modality.
Thank you, Julie. David, What are the future opportunities for ExPEC research? You're big on the ARLG and the antimicrobial resistance clinical trials. So tell us a little bit about what do you see the opportunities, and for reducing antimicrobial resistance, what kind of trials and research do you think would be most beneficial?
Yeah, I think that's a great question. Well, first of all, I think the impact, as you nicely showed as well, the impact of vaccines on antimicrobial resistance should really not be underestimated. Every successful vaccine has really very clearly shown that, specifically for pneumococcus, that you not only see less disease, but the disease that you see tends to be with more susceptible strains. So that's really a very elegant way of decreasing antimicrobial resistance. The second type of trials, and we're starting to see, a number of these, as you know, is how better to use the antibiotics that we currently have available. So not so much trying to get yet another antibiotic approved, but really trying to figure out some really quite basic questions like how long should we treat this patient for, and who all falls into that category. Because, of course, we've had a couple of trials now showing, for instance, again, as both of you know, for bloodstream infections with E. coli, 7 days is enough. And no, not every patient population is equally represented in those trials. So you still see a lot of exceptionalism. And of course, doctors, clinicians tend to be guilty of that. Often is the thought of, but my patient is different, and my patient needs a longer duration. The other question I think that is quite fair is that, do all patients really need 7 days? Is there maybe a patient population that is within that group that for instance, with 3 days would be enough? Similarly, other sort of very basic questions like when do you need 2 antibiotics, those types of things. And then to your point about stewardship, how do you most effectively bring a stewardship program to fruition? What are the components that are really most effective? Which are the components that lead to the combination of better outcomes and less antibiotic use? So let me stop there. But I think those are some examples of very high impact trials.
Excellent. Thank you so much. So some of the other questions that we're getting, and we only have 5 minutes, are, do we see a role for vaccines as part of the antimicrobial stewardship guidelines? I'm going to go very quickly. My personal opinion is yes. I strongly think that as we get more clinical information and the utility of these, I do think that stewardship guidelines, and actually every guideline, should incorporate the role of vaccination. What do you think, Julie?
Completely agree. Yeah, I think we're going to see more of this because it's a multimodal approach.
What about you, David?
Yeah, exactly. I think vaccination, you cannot emphasize it enough. It's just such an elegant way and such an effective way of decreasing disease.
So some of the other questions that are coming is, what about the potential value of vaccine in the nursing home? A lot of UTIs and urosepsis in that setting. And another question was, which would be the highest risk of chronic illnesses that should receive a vaccine if a vaccine becomes available? So what are your thoughts, Julie? Nursing homes and other high-risk groups. We have...
Absolutely. Yeah, I think, and the proof is in the pudding. I think we have to wait for the phase 3 clinical trial data. Hopefully those phase 3 trials will be inclusive, and the patients that are enrolled will be generalizable to those that would be, admitted into nursing home. But I absolutely agree that's a high risk patient population for suffering from ExPEC morbidity and mortality. So I know many pharmacists would be very interested in trying to get access to patients at those sites. So that's for the first question.
Yeah, I'm going to wear my infection control hat here. I just want to make sure we make a distinction between catheter-associated UTIs and non-catheter-associated UTIs too, right? I always say the first is remove the device if you don't need it. So same thing in hospital-acquired urinary tract infections. Many of these could be prevented by avoiding the use of urinary catheters when we don't need them. But yes, definitely nursing homes, elderly with recurrent UTIs. David, what about you? Transplant patients? Any specific group that you think would benefit benefit from these vaccines?
Yeah, so in my own practice, certainly kidney transplant patients, and I think back to your point about stewardship, of course, our primary target would not necessarily be asymptomatic bacteriuria, but if you have a vaccine that decreases asymptomatic bacteriuria, you subsequently also decrease the inappropriate antibiotic use, which of course shouldn't be there in the first place. But if you make that go away, that is great, certainly in the kidney transplant population, but also in the nursing home population. And then in the nursing home population, especially, it would be quite interesting once we have one of these products or hopefully multiple products that are approved and that seem to be effective, to really study them very specifically and see what is the impact, what kind of coverage do you need to really break these transmission cycles that you see in these types of places where infection prevention is just so difficult, as Dr. Abbo, as you know better than I do.
And then there's one more question that I honestly don't know the answer. It's how frequently would vaccines be administered? I think we still need more data. We would need to determine what's the immunogenicity that they're triggering, what's the adverse event profile, how long do they last, how effective are they, make sure that they don't have immune evasion. So I think that's information to follow. And but we don't know yet how often they will be necessary, if this would be a one-time dose or if this would be something that you would have to do through series. I don't know if any of you have additional thoughts.
You can see that they're trying to look at that. So in some of the data that Dr. Abbo presented, they're discussing the durability of the immunogenicity, and some of them have antibody responses to up to a year out. So I think that's preliminary. Obviously, it would be nice if this was a one and done kind of thing, but understanding the complexity of E. coli, both with the commensal populations and ExPEC populations that we've discussed, I have a feeling this is probably going to need some redosing over the course of an individual's lifetime if the indication is still there. That is 100% my guess based on the preliminary data that we've seen. The other thing that I think we could probably glean from is like that oral vaccine that's approved internationally that is not yet on the U.S. market. The OM89, it looks like a relatively long course for that series over many months to prevent recurrent UTI. So if that gives you a sense, this is something that's probably not as simple as a 1 or 2 dose series and then you're done for your lifetime. I don't think that's the indication that we're getting. But again, it is very early to say. That's just my opinion. But I don't know if David has anything else to add.
No, I would agree with both of you that it's probably too early to say in general. I do get a little bit of hope from our experience with pneumococcus, which obviously gram-positive and quite a different organism and different sort of a niche in anatomically. But I think, it's certainly we have the example of an antibacterial vaccine that works extremely well, combats AMR, and really, if you get a shot, you're pretty good for, we don't really know, of course, but at least like 5 years, you're in pretty good shape and probably longer. And then if you combine it with sort of a population impact, so I'm sort of mild to moderately optimistic that it wouldn't be, like the flu or COVID model.
Very good. Well, we're running out of time. I really want to thank Dr. Justo and Dr. Van Duin for their amazing presentations. To all of you for attending with us today. If you need to access this, it will be available. We have podcasts, clinical thought commentaries that our speakers have done. And there's also the downloadable slide set that will be available. So please go to clinicaloptions.com, infectious diseases. Thank you all for attending and have a great rest of the week.
Thank you very much to our faculty, and thank you to our listeners for joining in. Please be sure to check back for more episodes on important infectious diseases topics. Thank you, and have a great day.